Welcome to the LongCovidPodcast with me, Jackie Baxter. I am really excited to bring you today's episode. Please do check out the links in the show notes where you can find the podcast website, social media and support group, as well as a link to buy me a coffee if you are able. You should not rely on any medical information contained in this podcast and related materials in making medical, health-related or other decisions. Please do consult a doctor or other health professional. I love to hear from you. If you've got any suggestions or feedback or just want to say hey, then please do get in touch. I really hope you enjoy this episode, so here we go. Hello and welcome to this episode of the Long COVID podcast. I am super excited today to be joined by Hadas Golan and Rosalba Courtney, and we are here to talk about my favourite subject, which is breathing. So these guys have just released a paper, I think is that the correct word, on basically how amazing breathing is. So we're going to talk a load about that and dive into all sorts of rabbit holes, I'm sure. So a very warm welcome, both of you, to the podcast.
Thanks, Jackie.
So to start with, would you mind saying a little bit about yourselves and I guess what it is that you kind of do?
All right. Just to add to what you said about the paper, there was a third author, Jeremy Wolfberg, who was a graduate intern working with me at the time that I was doing the beginning of my work with long COVID. And so he helped with the measurements and the writing of the article. And now he's doing other really important research as a PhD student at Mass General Hospital, but not related to breathing anymore. And introducing myself, I'm a speech language pathologist, or SLP, and I specialize in upper airway and kind of breathing and voice disorders. So medical SLPs like myself, we treat disorders of the upper airway, meaning vocal cords related. So, hoarseness, cough, and vocal cord dysfunction, which is a condition with many different names, where kind of the people cannot breathe and the problem is in the valve, kind of in the vocal cords. They can't breathe in. And I work in Boston University Medical Center in a department of otolaryngology, or ENT. But my real interest in breathing started after my lifelong asthma was healed with the Buteyko method. And that was kind of complete, kind of life-changing. And after that, I wanted to help others and spread the mission, really spread the word. I was so excited about that. So I became a practitioner and then trainer, and I developed courses for speech pathologists, promoting the idea that they need to be trained in dysfunctional breathing, the whole system, not only the upper airway, because it's common in our patients' population. But, over the years as a Buteyko practitioner and a clinician and a health professional, I had some unanswered questions with Buteyko. And I felt like it's only one piece of the story, and many patients might benefit from other approaches. And when the pandemic started, I finally had the opportunity to get trained with Rosalba.
I guess that's my turn to talk now. Okay, so I'm Rosalba Courtney, and my background is that I'm an osteopath. Also, I've trained in other allied health areas as well. But when I was a long time ago, probably more than 30 years ago, I know it was 30 years ago because it was when my second child was born, and I took some time out of my practice and I decided to really focus on learning more about breathing. And at that time, the Buteyko method had just come to Australia. So I got very involved with that and, became chairperson of the association and traveled to Russia and met Buteyko and started training practitioners, doing training courses with practitioners and working with patients. But it was like similar to Hadas, the more I learned, the more questions I had. And I ended up with more questions than answers. So then some of the big questions were like, how does breathing really heal? Do you know? And what is dysfunctional breathing? In the 90s, there was a lot of controversy around what is hyperventilation? Is dysfunctional breathing hyperventilation, or is it something else? And so I actually did a PhD, which, lasted for a good 8 or 9 years. And that PhD was called Dysfunctional Breathing, its Parameters, Measurements, and Clinical Relevance. And out of that, I developed some models for assessing and treating and thinking about breathing disorders and breathing therapy. And that became integrative breathing therapy. And when the pandemic came, I'd been teaching people just where I was in Australia or traveling and doing some courses. But when the pandemic came and I had a bit of time out of work, I actually developed a practitioner training course that ran over about 6 months. And Hadas was, in that first cohort. And, she's an amazing breathing practitioner in her own right, didn't really need me at all. But anyway, it was really great. And, that's where our collaboration started. And Hadas has done amazing work with long COVID. We both got very interested in long COVID. I got very interested in the research and looking at what is disordered breathing in long COVID. How does it affect people? What's likely to be, the most useful approach? Because the whole IBT model is that, the treatment's never about the technique. It's never about the technique, which I'm sure you would agree, Jackie. It's really about, what's going to work for this person? How do we solve this problem? And how you solve the problem has to do with understanding, the pathophysiology of the condition, what the different ways that breathing is impacted, how potentially could you best work with breathing to, impact that particular problem that you've got, and how do you adapt what you're doing for the patient. So Hadas really took that into her. She was seeing a lot of long COVID patients, and she really took that integrative breathing therapy model, which is a very structured assessment, which Hadas, I'm sure, we'll talk about a bit more. It's a very structured assessment, and then there's a protocol that moves through. The unified breathing system is one of the ideas, that the nose, the upper airway, the lungs, they're all connected. And she developed a protocol, or delivered the protocol, which moved through all the different systems that worked with all the dimensions of breathing as well. That's the other idea in integrative breathing therapy, that breathing is multidimensional, that it's got a biomechanical, meaning like the muscles and the movement and the patterns of breathing, and a biochemical, which is about oxygen, carbon dioxide, pH, and then a psychophysiological component, which is that mind-body aspect of breathing. Anyway, so that's a very long introduction, introducing integrative breathing therapy and myself.
Amazing. And I love what you're saying about it's not a one size fits all. And I think, no two people are the same. Nothing is ever a one size fits all, but certainly from what I've experienced with long COVID and what I'm now seeing with the people that I'm working with is that, people with long COVID, and I think this probably includes other chronic conditions such as ME and stuff that I have less personal experience with, is that these people, they don't fit into the sort of traditional breathing models, or if they do, it's in a very special, sort of careful, gentle way. And I think this is where, the sort of adaptation of existing stuff, exercises, protocols is important. And it's not to try and sort of stuff them into the asthma category or the whatever other conditions that you sort of traditionally see. And this is really interesting to me as well, because this is kind of what I've been doing. Maybe before we dive too deep into that bit, we should do a kind of what is dysfunctional breathing? And I know, you've just kind of alluded to the fact that this isn't really just one thing, but maybe a kind of overview of that would be really helpful.
So it's interesting because in recent years, people have been starting to interchangeably use the terms dysfunctional breathing and breathing pattern disorder. You might hear that term more in the UK. They're using that term breathing pattern disorder a lot. But in the literature, you'll find the term dysfunctional breathing. And so from a Buteyko perspective, dysfunctional breathing is always hyperventilation. It's always, breathing out more carbon dioxide than your body makes. There are two dimensions. So a breathing pattern disorder would be one dimension of dysfunctional breathing, and hyperventilation would be another. But then there's this other dimension of dysfunctional breathing, which is just when the person is not accurately perceiving their breathing. So they're over-perceiving or under-perceiving their breathing. And breathing has become a symptom. It's become alert, if you like, symptom, like pain becomes a symptom. So there's something disordered in the perception. So people are hypervigilant to breathing, or they're just disconnected from breathing, and their breathing is carrying messages of distress and unpleasantness, and they can't access, relaxed, pleasant breathing. So that's kind of the three key dimensions. So dysfunctional breathing is breathing, here's my definition, breathing that doesn't fulfill its primary or secondary functions, right? The idea being that breathing has lots of functions in the body, and those functions change depending on what you need the body to do, right? So you breathe differently if you're exercising, the breathing pattern, the CO2, everything needs to change when you're exercising. So the different functions of breathing are really much more than just moving air in and out of the lungs. Breathing functions as a rhythm, as an oscillating pattern that interacts with lots of different systems in the body. Breathing is talking to the heart. It's helping to move venous blood back to the heart. It's very important for speech and vocalization. It's important for core stability, and it's part of the movement system. It's integrated with the movement system. So, it's like whenever breathing isn't fulfilling its functions well, it's dysfunctional, and it can show up in different ways. So if you're coming at it from a clinician, who has a clinical problem to solve, you try to understand how the breathing arose from that condition and how it might be reinforcing that condition. So dysfunctional breathing is breathing that doesn't have ears. So it means it's not efficient, adaptive, appropriate, responsive, or supportive of body systems. And I hope that's not too complicated a definition, but it's kind of, to say it simply, it's just breathing that isn't doing what breathing should do, and it doesn't feel good. It's leading to symptoms, and it's reinforcing the person's condition.
Yeah, and I think this is amazing, because me of 4.5 years ago would have said breathing is just something you do. There's no right or wrong way of breathing. You either are or you aren't. And it's amazing how your perception of that can change as you discover it in whatever way that is for you. For me, it was through having experience of long COVID and discovering that my breathing was dysfunctional. And and now kind of understanding that, and it's not just some woo-woo thing either. It is literally everything in the body. It affects every single part of your body. It's not just anything. And it really is that kind of incredible power of it. Anyway, yeah, I get so excited talking about breathing. My partner always tells me to stop talking about breathing because it's all I ever talk about. So I think while I'm talking to you guys, I can talk breathing, right?
Yeah, you can talk about it for weeks.
So yeah, dysfunctional breathing and long COVID, or, more widely, chronic illness. Why is this such a problem in chronic illness? Or is it more just that it is more apparent in someone with chronic illness?
Yeah, that's really interesting. Something trying to understand. It's like people with long COVID is primarily a respiratory illness, although it hits the blood vessels as well, and it can affect, especially with long COVID, affect all organs of the body. But you could say it starts off in the respiratory system, quite quickly moves into the vascular system. And we know that the respiratory and the vascular system are quite linked. So people who develop ongoing symptoms within the respiratory system, they often show up with dysfunctional breathing. So the breathing pattern changes, and there can be hyperventilation and also, breathing distress around breathing. And the reason that is I think my current feeling, and I'd like to hear what Hadas has to say, but my current feeling is that, it's often driven by the bit of damage that's been done, to the lungs and to the vascular system, but also to the mitochondria. Because when Hadas and I both measure carbon dioxide in our patients, and we do find that, there's a lot of hyperventilation. And the more severe the patient, the more likely they are to have hyperventilation. But they're not breathing quickly. They're not like your classic hyperventilator. So my thought is, so what's going on? So there's more CO2 being breathed off than is produced. But the breathing doesn't appear to be excessively rapid or even deep. So is it really a problem with internal respiration? Is it really a problem with the mitochondria, not making CO2? So in some ways, the hyperventilation that you see in long COVID might be functional, meaning that it's responding to something that's gone on in the body. The body still needs to get oxygen, right? So the person's still breathing to get oxygen. And if you just give them classic reduced volume breathing like one would in Buteyko, it makes them feel terrible. They can't do it. It makes them feel terrible because they're not low in CO2 because they're over breathing. They might be low in CO2 because they're underproducing. So the point being then, they're not picking up, oxygen well, and they're not matching, ventilation to blood flow very well in their body. So there's a background of pathology that's driving all of this. And they're trying to get by the best way they can. So in working with breathing, you've got to work quite, gently. But still, okay, so you get a person who then has been hyperventilating for a while. What we know is then that develops a whole lot of compensations in the body, and those compensations can become problematic in themselves. So that means that you work very gently to correct the hyperventilation, taking into account that way that person's breathing is in a way functioning for them. So you can't just come in with all guns blazing, to try and fix that. And then looking at some of the other research studies that have looked at the dysfunctional breathing in long COVID, they go, we found diaphragm dysfunction. There's weak, small, thin little diaphragms. These people have not been really using the diaphragm to breathe. And so, a lot of the treatments are around, inspiratory resistance training and, training the diaphragm to strengthen the diaphragm. And it's really interesting. Why is that diaphragm gone weak? So it's because maybe the breathing pattern has changed, and so they haven't used the diaphragm. So it becomes important to train the diaphragm, because that diaphragm and the strong, good action of the diaphragm is part of what's helping venous return. It's helping the blood get back to the heart, which then becomes your stimulus for improving the function of the circulatory system and venous return and the blood going back to the heart. It's really important for beginning the respiratory afferent activation and the baroreflex activation of the vagus. So it helps with the dysautonomia. Anyway, I hope that wasn't too technical, but so there's sort of all these levels, the breathing goes wrong for a reason, and it's sort of serving a purpose in a way, but then it becomes its own problem. So you want to try and fix it with kind of a respect and with patience and with realistic expectations about how much you're going to be able to achieve. So knowing that, that person may need help on lots of levels as well. And then on top of that, people who are unwell just become psychologically distressed, and they often don't sleep well. And the autonomic nervous system goes into disarray, and the sympathetic nervous system, the sympathetic nervous system is activated in infection. So often the high sympathetic arousal is because the body's still trying to deal with infection, or the sympathetic nervous system's been activated by the infection. So in a way, even that you've got to have a bit of respect for. It's not just that a person's neurotic because they're in sympathetic dominance. It's really that their body has responded to this illness by doing this stuff. So then you work very gently, carefully to work on all of that. And then, of course, there's the nasal obstruction, nitric oxide, the effects on the upper airway and so on that occur. And that's all within that protocol, that Hadas and I have been using with our patients, where we work on all those parts of the breathing system, but in a kind of a gentle and a respectful way, respectful of the body, and its intelligence, if you like.
The first thing that really surprised me, I was there very early before the literature came out on long COVID. So it was really, I was using my own I was very excited. I just finished Rosalba's course and I was equipped with even better understanding of dysfunctional breathing and how breathing interacts with and influences other physiological systems, and how dysfunctional breathing can really disrupt homeostasis in these systems, and how you can also use breathing to restore balance in these systems. And then long COVID really called my attention because I said, well, I don't know anything about it, but it kind of sounded familiar, like to other conditions I was treating, including, of course, asthma and anxiety and the ME/CFS. And so like the complex nature and the multiple physical symptoms, cognitive symptoms, and like it sounded familiar. So I kind of reached out to the long COVID clinic in the hospital and I said, I think I can help. And they were really more than happy to send their patients to me, because all they did was I'm not dismissing that, referring people to other to specialists, only to find very little, and referring to mental health professionals. So really, they're like very limited treatment options, or really none. So I started to get a lot of patients, and I was really doing everything by the protocol. I was so it's starting with a good comprehensive evaluation. So the first thing that really called my attention was the extremely low CO2 in many of them, not everyone, but like in the 20s, not like before. I saw it in asthma, like 30, 32. So it was not severely low. So really, really low. And then I asked myself, like, why is that? I didn't think, I wouldn't say, oh, all these symptoms are because you're hyperventilating. No, it was very obvious that these people are really sick. And then, so it didn't feel right away to correct their CO2 with Buteco. So I really appreciated that I had all this knowledge from the course, that I can start super gently. And even then I had to really, I learned from the patients a lot, how to, like, very quickly I realized, no, I need to really slow it down and even tone my own energy down, so I'm not overstimulating them. And really, because I had, really my schedule was overwhelmed. So I just, okay, let's do patient groups. And that also because my session is not long enough. So that allowed me to explain the theory behind everything and introduce information. But then really crucial was that it was combined with individual therapy sessions, because that's all the information I gathered from the evaluation. Super important. And I can talk later more about what exactly we were measuring and the findings.
Yeah, and I think the community element, the groups actually are incredibly powerful. We are starting to understand now more about the nervous system and how important that social connection is for our nervous system. But when you have something like long COVID, you are out of energy, you are feeling terrible all the time, you may be not working, you're maybe not able to do the things that you used to do, so you're not seeing the people that you used to see, and your world gets slowly smaller and smaller and smaller. And then bringing people together to breathe together you're doing something that is practically useful. So you are teaching them a skill that is going to help them, that they will see that improvement, even if it's just 1% at a time. But you're also, I think, just as importantly, they're joining together with other people. They're getting that validation. They're seeing faces. They're interacting with people. And I think that in some ways is maybe as powerful as the breathing itself in some ways, for sure.
Absolutely. I think that was such a great success. Again, it was very early on. People didn't even know that there are other people dealing with similar things. And I think again and again, since the beginning and until now, how people feel a lot less alone or isolated, invalidated. And it became really the first classes were really became like support groups until they took it out of my classes because I didn't have time to teach anything. But it's so important. And then also dynamics, because some people obviously improve better than others. But when someone tells about, how how it went for them and what they did, they really learn from each other and support each other. And it was just awesome. Yes, and still is.
Oh, absolutely. I find the same too. And it's a big factor is the motivation factor, keeping people going. Because one of the things when people are unwell, they lose motivation to do things for themselves. And so it's having the structure in place to keep them going with a thing and hearing that other people are improving or that other people had a dip and then got better. Do you know that just because you had a backslide doesn't mean that you're going to keep backsliding, that you can keep going forward. It's that kind of encouragement and motivation element as well is hugely important. So yeah, thank you, Zoom. Thank you, online. It means that people who can't leave the house can actually participate, and get the benefits of the group support. Yeah.
Yeah. At the same time, while I really learned to work and love Zoom and telehealth, I think the in-person and the measurements were so important. I miss things when I see people on the screen. And somehow I'm still able to help them better when I actually see them with the hands on, and
you can see more and feel more and do proper measures. Yeah, this is true. Absolutely. So you need at least that initial measure if possible, right? That's what I find too. You want that initial measurement so you can see how low is this CO2? What is that breathing pattern doing? How does their upper airway look?
Yeah, and then we used it's called the MAR, the Manual Assessment of Respiratory Motion. It's where the clinician is sitting behind the patient with the hands on their posterior diaphragm. And you're just assessing for how balanced is the upper rib cage movement to lower rib cage and abdominal motion. So that was also interesting. I think the most common pattern was very fast and very shallow, to the point that I really have to stay there for a while to see, what do I even feel? So that was one pattern. And others were kind of irregular, intentional, kind of effortful. I don't think I could see it if I didn't put my hands on them. Yeah, and then symptoms questionnaires. So we used the Nijmegen questionnaire, which is a list of symptoms that originally was for hyperventilation, but now is dysfunctional breathing. And then we use the self-evaluation breathing questionnaire, which also kind of asked about quality of breathing, quantitative and perception, patient perception of breathing. And then there is one tool that for upper airway called dyspnea index, which is also kind of just to quantify these symptoms. So initially, they all scored pretty high on all these measurements, and there was improvement after the treatment in all the symptoms questionnaires, as well as the biomechanics improved, and the CO2 has increased as well after treatment, which was super cool. And the most exciting is that with that, also symptoms improved, and people really became more and more functional, which is really what we care about the most.
We'll be right back. I'm interrupting myself for a second to tell you about long COVID breathing. The fabulous Vicky Jones and I have teamed up to bring you long COVID breathing. We are both passionate about sharing our expertise and experience of the breath and how incredibly helpful that can be with long COVID. We've worked together to develop a course that is specifically tailored to those with long COVID. It's a 6-week course with 12 sessions, all delivered online. The community feel and learning that we're all sharing is such a joy. To find out more information and to sign up for our courses, workshops and other shorter sessions, please check out the link below, longcovidbreathing.com, or email longcovidbreathing@gmail.com to start your breathing journey with us. Yeah, I think you're right. I think, obviously for the purposes of research, you need to be measuring things because you need that objective data in order to, actually be able to have your results and to publish them. But actually, if you were to ask someone with long COVID, do you want your CO2 to increase? They would really not care. What they would care about was, I want to feel better. I want to have less symptoms. I want to be able to do some of the things that I couldn't do before. So yeah, I think that is the mark of how people feel. But yeah, for sure, for the research, you do need those numbers.
Oh, and for the clinician to be precise with their treatment, then you know which techniques to focus on. That's what those measures give you. So you pick up in that assessment, how you need to tweak it for the person. And then you can also, because you reassess, and then when you reassess and you go, oh, that really improved, but that didn't. So let me change the techniques so that they'll get this to move, or let me look deeper into trying to understand why that particular metric, didn't improve. So that's where the kind of precision, if you like, the precision of the stuff comes from the assessment. Because patients just want to feel better, but it's sort of like that's a very blunt sort of measure, just feeling better. You want to know that you're going to feel better, that feeling better is robust, it's stable, it's going to last, it's not going to tip over. And when you've really made the body function better, when you've really improved the physiology, then that improvement becomes, stable. That's what I would say.
Yeah, absolutely. Yeah, because, I feel better is very subjective. And that's great, but it's not a lot of use in your research paper. And yeah, I suppose like you say, you don't actually understand what's going on internally if someone says, I feel better, although that is obviously a great result.
Bottom line, it's the only thing that matters in the end, isn't it?
It is.
Just
Yeah.
having that be strong and stable and last is the thing. Yeah.
Yeah. So, how did you recruit people for this? Was there a sort of inclusion criteria? What did they need to have breathing difficulties, or was it sort of anybody? How did you do that?
The people who were referred to me were people with long COVID and dysfunctional breathing. So that's kind of the people I included if I diagnosed dysfunctional breathing, which was really easy. Everyone I assessed, only later on I saw a couple of people who didn't have it. I didn't think their breathing is, but at that time, yeah, it was all dysfunctional breathing. And because I'm working with, third-party pair, then they also needed to have some upper area related or speech related diagnosis. So people were having either hoarseness or cough or stuttering or this vocal cord dysfunction that I could also. And obvious, they had the long COVID symptoms, like the chronic one, like the chronic fatigue and the insomnia and the brain fog and anxiety, etc., exercise intolerance. The exclusion was real pathologies like cardiovascular or pulmonary pathologies. And then we really picked the 5 consecutive patients that I could complete the measurements on time. It was a very hectic time with kind of limited in-person availability of me and the patients, So it was really, that was the challenges at that time, to see people for the measurements before and after. So it's the first 5 that I got the measurements.
Which is really significant in itself, because it means that she didn't just pick her best patients. She did 5 consecutively, which is important for research because it shows, no, this is a thing that's consistently, working in this type of patient.
I definitely didn't pick the ones who improved the most. I wish I could, but yeah, but it wasn't. Yeah, like all of them really improved. Some of them got really near normal function, and some of them not, but still the improvement was very impressive and significant for them.
Lots of ups and downs too.
Absolutely, yes.
Just to encourage the people with long COVID who might be listening. Lots of ups and downs, keep going.
Yeah, and the group was a great because, and I think I also I have this, whenever people see me, they come out a little more motivated. I'm a good cheerleader or giving hope and just encouragement. And but yeah, lots of, and people also got COVID again and again. Some of them, but the cool thing was that they were saying how much, especially the longer they were in the program with me, they were using the techniques, like lots of humming and breath holds and slow breathing, and they were using it, and they believed that that's what kept the long COVID symptoms from getting worse.
Yeah, because I talk about this all the time. My breathing was it was the first thing that I found that helped me with long COVID, and that really then put me on the trajectory to find the next thing and then the next thing that helped me to eventually recover. But I still use these breathing exercises in my daily life now, all the time. It's a skill that's going to help you with recovery, but it's also a skill for life. Because life isn't perfect when you recover. Stress still happens. You still get sick. These things do still happen. And, having that foundation of functional breathing and, being able to impact your nervous system and all these things, like you still need them. That's still super, super important. So I talk about this all the time, how important that is. So yeah, I'd love to talk a little bit more about the protocol. I think is that the right word? We sort of talked about what it was based on. So yeah, it'd be cool to dive into a bit of how long did you do this for, and was there any sort of modifications that you made when you were working with the long COVID people?
So there was evaluation sessions, sometimes 2, just because again, my sessions are not long enough. And hearing the full story first and getting this talk sometimes takes the whole session, and then the measurement takes another session. But evaluation. Then at that time I was having 6 weeks, once a week, 1 hour Zoom class, group class. And then individual sessions, it all really varied. This is why it's not a great research, because again, it was a difficult time. So the individual sessions were between 1 or 2 and 4 individual sessions. And then many people, again, especially at the beginning, because I was still modifying and learning, people really benefited more when they took the class again, like 6 more weeks, started from the beginning. And we found that really this is when they started to notice like the techniques help them. Before that, it was all just exhausting and like they were seeing it through the fog of everything or falling asleep so I did record every class, and they got handouts, and they appreciated that. So, and because I really kept encouraging them, if you don't feel well, you just lie down, you can rest, you can fall asleep. I really gave them permission to do that after I saw how bad they are. So the first 2 sessions, and it was all following Rosalba's protocol, just slowing it down, was improving nasal functions, talking a little bit of breath awareness, posture, but nasal functions, and which really covers all the 3 dimensions already, which is very cool stuff. And after that, there was mindfulness and mind-body connections, training gentle diaphragmatic breathing. And each one is 2 sessions, and then addressing hyperinflation and hyperventilation. And then we did resonant frequency breathing, which is slow breathing. I think you call it cadence, right? It's this 4 in, 6 out, but building towards that. And then later on, I felt that people really couldn't tolerate reduced breathing. So we switched the order. So we did slow breathing first. But in this study, it was still, we take it first, over reduced volume breathing first before slow breathing. And then we also covered how to pace yourself talking and breathing and the physical pacing. I really learned that people don't understand what is, like they sometimes weren't aware that they are pushing themselves beyond their capacity. So even walking from the waiting room to my office, I could see that they're walking way faster, and then they reach my office and they're so breathless. And then, or some people just wouldn't stop talking, which is also really, so if they're hooked to the capnometer and they see that after talking, their CO2 goes to 15, that's the lesson. So I really worked with people how to pace themselves. And then individual sessions, we just, reinforced whatever was individual for them, or their challenges. So after at least one course of 6 sessions, some people were remeasured then. Some people were remeasured and then kept going and took it the second time. So, but at least 6, after 6 weeks, there was the second measurements.
Yeah, and I think this is so awesome. And you're talking about sort of 6-week blocks. And, breathing is incredible and it has such an amazing impact on everything in the body, but it takes time. You don't start doing something that is new to you and suddenly become really good at it. You have to practice as a musician, as a music teacher. This is something that I'm very used to kind of instilling into people and that I'm used to doing myself. You don't pick up a piece of music and are instantly able to play it. And you don't go from having a dysfunctional breathing pattern to instantly your breathing being perfect. And when you're talking about working with people with long COVID, for example, these people are severely fatigued, they've got cognitive challenges, they've got dysautonomia. You can't make these changes fast because actually that's going to make things worse. So like you say, that 6-week block is important. And then actually, as you say, maybe doing it again. Maybe that's what they need. And did you see more improvements in the people that did the second 6-week block, or is that not something that you're able to measure?
Yeah, absolutely, yes. And now I kept work. I think I saw around 80 people. I counted before kind of talking to you today. So people stay again. Like they just, first of all, it really helps them to stay with the program. I think if you leave after 6 weeks, I don't know, it's very hard to continue on your own. So people choose to stay and continue. And I have the advantage that it's built, their insurance pays for that. So people can afford it too. And it's at home, so it's easy. Yes, absolutely. I find it the people who stay longer, and there is so much more that I don't cover in the course, and now I offer what I call advanced breathing course, which doesn't mean that the people are with less severe long COVID. It just means that they heard me enough that they move to the next. So there is so much more that we can do, and definitely the people who stay longer have much better results.
We'll be right back. Hey there, I'm just jumping in for a second to see if you're enjoying this episode. If you're finding it useful, maybe you would consider sharing it somewhere, a friend, a group, or even on your Twitter feed. If everyone was able to share just once, we'd be able to get this information out to even more people who really, really need it. So please consider sharing somewhere if you possibly can. I hope you enjoy the episode, and thank you so much.
Yeah, for sure. I just wanted to say something about the, like getting your breathing perfect and breathing in the right way and learning to breathe correctly. One of the ideas in integrative breathing therapy is that having rigid ideas about perfect breathing is counterproductive, and that it's actually really important to understand that the way that you're breathing is a reaction or a response to the things that have happened to you, and your history, which might be trauma or COVID or whatever, and that it's a lot of it is about listening to and observing the breath, and it's actually about developing a new relationship with your breath, so that there's a lot of time spent in, listening and observing and noticing natural changes. That's part of the protocol too, is about noticing and observing natural changes in breath that occur with different things. And then being able, by observing the breath, to know yourself. So therefore to be able to, be better at pacing or better at knowing that you need withdrawal time or whatever. So rather than always like doing something to the breath, it's also about noticing and feeling and developing a new way of kind of relating to the breath. Because the big difference, I think, because Hadas and I have talked about, other breathing techniques. I haven't looked at your program, Jackie, but, other things, it was all very much everyone's taught to do the same box breathing, or they're taught to do resonance frequency breathing, in for 4, out for 6 or whatever. And that's all they do. And that's really missing big part of the story, because it's not just about imposing something. It's like if you go to a cocktail party and someone just talks to you and they don't listen. They are so boring. It's such an inefficient communication segment right there, because there's not sufficient, listening and kind listening. And it's like that kind listening is what needs to happen with the breath, with very sick people, with long COVID, with ME, CFS, with people that the system has lost homeostasis and it's become hugely dysregulated. You have to be really able to be with what is and listen and be kind listening,
Yeah, absolutely. And I loved what you said about perfection. I mean, I'm a recovering perfectionist. I think, it's not everybody, but I think this is quite a common trait in people with long COVID. I love it when people who, are working as breathing instructors are working, in that sort of world. And they talk about how they still practice breathing. And I'm like, this is great, because even the people who are the best at it, they still practice. Your concert soloists, they still practice. They probably practice more than anybody else. Nobody is perfect. We can all be better, and we can all, as you say, listen into our breath, because it changes all the time. The way that your breath is in the morning is not the same that your breath is in the evening, and it's not the way that your breath is the next day. It's such a powerful tool in just so many ways, isn't it? It's just, yeah, it's awesome. I think this is brilliant. So what is next? We've cracked long COVID with breathing. I mean, we haven't. But you've proved that, you can see a huge amount of improvement by doing better breathing, for want of a better word. So where are you going from here? And what are you maybe hoping that other people might do with what you've produced? I suppose that's a really big question, isn't it?
Yeah, I know Rosalba has a lot of ideas about what research should happen. And personally, I'm a clinician and I'm very busy. Like I really literally spend all day seeing kind of many, many, like patient after patient. So I don't have a research capacity, but I continue to see the patients and continue to get new referrals every week. And I just collect the data as best as I can, hoping that one day either I will again make the time or someone else will get interested to look more deeply into that. But definitely there is much more interesting research that like understanding the mechanism that Rosalba will talk about.
Yeah, I mean, I'm a clinician too, as well as a researcher, and I just think, Hadas and I both, as clinicians, what's happening, what we want, maybe implicitly, which I might state explicitly, for both of us, is that we just want to keep learning to do what we're doing better and better. And we do that by doing what we do in a structured way, and using kind of assessment tools and then reassessing. And then, so kind of what we want to keep doing is talking to each other and learning how to improve what we do. In terms of getting the word out there, Hadas can't see any more patients. Back to the rafters. And, I mean, we both do want to see patients, but it's like what we want to do is to train more people, really, to be able to do this. So more training so that it can go out to more people. And research would be fantastic. And the research that's happened, in breathing therapy has often been quite siloed and narrow. It's just been on a particular technique, diaphragm release with some inspiratory muscle training, or just, on a particular technique or combined with exercise rehabilitation. I did a literature review, actually. I think I ended up with 13 studies that had used breathing as an intervention, but a lot of them weren't terribly well structured, it's like they hadn't fully committed to really understanding breathing. And I think that this particular protocol is unique, and the refinements of this protocol, really should be studied in a bigger cohort, maybe with a control group. Usually, with research, you often start off with a case study or a case series like this one here, that we published. And then the next is to do a pilot study that's bigger, or then to do a controlled trial. But we'd need kind of resources and help and other people jumping on board, to help with that, because we're not in the position to really do that. So sort of reaching out for anyone who wants to test this protocol in some format that goes beyond the case series. And then also, I do more of this integrative breathing therapy practitioner training, the general training. Perhaps Hadas and I could do some mini trainings on long COVID and breathing techniques. We haven't spoken about that. That's a possibility. That kind of thing.
But also look into mechanisms, kind of how breathing retraining will affect, like what will it look like in the brain and MRI, kind of.
Yes, exactly. Yeah, what's really changing? Like, we know that the measures of dysfunctional breathing are changing, the CO2, the breathing pattern, the symptoms, that's improving. But what else is improving, in the pathophysiology?
Yeah. Oh, fantastic. Well, there's a wish list. I'm in. Let's see if we can get anyone else, and let's make this happen. Guys, thank you so much for giving up your precious time and energy to chat to me. This has been an absolute pleasure. I feel like we could continue all night. Yeah, thank you so much. And yeah, all of the links that you've mentioned will go into the show notes if anyone wants to check out any of that. And yeah, I'm excited to see what happens next.
Thank you, Jackie. Thank you so much. That was wonderful. It was wonderful talking to you.
Yeah, thanks for your great work.
Thank you so much to all of my guests, and to you for listening. I hope you've enjoyed it, or at least found it useful. The Long COVID podcast is entirely self-produced and self-funded. I'm doing all of this myself. If you're able to, please go to buymeacoffee.com/LongCovidPod to help me cover the costs of hosting the podcast. Please look out for the next episode of the Long COVID podcast. It's available on all the usual podcast hosting things. And do get in touch and